Welcome everybody to Department of Medicine Grand Rounds for February the 15th. This spring, we will have a series of updates from many of the divisions talking about new advances in each of our respective fields that are of broad interest for all of us. And so I'm delighted to launch that series with updates in infectious disease, featuring my colleagues in the Division of Infectious Disease. And so I'm going to go ahead and introduce the three speakers up front, and we won't interrupt them their discussions for introductions during the course of Grand Rounds. And then I'll moderate the chat for questions for all three presentations at the end. So our first speaker today will be Dr. Lauren Collins. She's an assistant professor of medicine here in the Division of Infectious Disease. She's a co-investigator in the NIH-funded multi-center AIDS cohort study, Women's Interagency HIV Study, which is a combined large cohort study of men and women. And she also is an investigator on the Emory Specialized Center of Research Excellence on Sex Differences. Her research seeks to improve the clinical care and outcomes of persons aging with HIV, with an emphasis on comorbidity science, women's health, the Southern HIV/AIDS epidemic, and promoting health equity. She also has taken the lead at our clinic at Grady, the Infectious Disease Program, or the Ponce de Leon Center, at launching our new program looking at long-acting injectable therapy for HIV, and that's what she'll be speaking on today. Our second speaker will be Dr. Jessica Howard Anderson. She's an assistant professor of medicine also in the Division of ID, and is as well the associate hospital epidemiologist at Emory University Hospital Midtown. Her research focuses on the epidemiology and risk factors for multi-drug resistant gram-negative infections, using novel methodologies to understand clinical outcomes of patients with multi-drug resistant infections, and employing diagnostic stewardship to improve antimicrobial prescribing and decrease healthcare associated infections. You can blame her for the regulations around C. diff ordering, for example. It'll make her very popular. She, however, will be speaking to us about new C. diff guidelines today, and it's something that I think touches on all of our physicians, regardless of where they practice. The last speaker in our series needs really no introduction to this group. It's Dr. Kimberly Workowski, who's a professor of medicine at Emory University, School of Medicine, Division of Infectious Disease, and as well holds an appointment at the Centers for Disease Control and Prevention. Dr. Workowski is a nationally known expert in sexually transmitted infections. She has, for many years, been the chair or lead author for the sexually transmitted infection treatment guidelines for the CDC that we all use as our Bible, and we eagerly, at least those of us in IB, for the new versions to be out every few years. And so she will be actually updating us on really new developments in the treatment of sexually transmitted infections. And so I'm delighted to have the three of them. They will talk today. They'll each give relatively short presentations. And again, there will be an opportunity at the end for questions. And so please feel free to put your questions in the chat. And so Lauren, Dr. Collins, why don't you take it away?
Thank you, Wendy, for the kind introduction. And it's a privilege to be here this afternoon sharing long-acting injectable antiretroviral therapy for HIV treatment and prevention. I have no disclosures. The learning objective for this portion of Updates in ID is to evaluate the novel clinical landscape of using long-acting injectable, or LAI, antiretroviral therapy, or ART, for the treatment and prevention of HIV infection. A brief outline: I will introduce LAI ART, evaluate data and clinical considerations for use as treatment and prevention, discuss implementation in the real world, and share a vision for the future. To begin, we have the opportunity with long-acting injectable ART to transform the landscape of care for HIV treatment and prevention. This opportunity includes not only that to improve clinical outcomes, but also the client experience by alleviating pill fatigue, improving adherence, and reducing stigma. Most importantly, we have an opportunity to provide more accessible and equitable care for persons with HIV and those at risk. Why so much opportunity? We know that disparities in HIV care, including access and outcomes, have been perpetuated for decades, as shown here by CDC data reporting substantial drop-off along the HIV care continuum by race, notably with Black, African-American, gay, and bisexual men having lower rates of viral suppression compared with all other groups of people with diagnosed HIV. In order to end the HIV/AIDS epidemic in the US and worldwide, we must do better. Although we have a lot of progress to be made, it's important to reflect on the substantial and tremendous scientific advances of ART over the last several decades that have paved the way for LAI options. Shortly after AIDS emerged in the US, HIV-1 was isolated as the etiologic agent, which led to the development of the first class of ART, namely nucleoside reverse transcriptase inhibitors, or NRTIs. And zidovudine, commonly referred to as AZT, was approved for use as monotherapy in 1987. In the years to follow, several other drug classes emerged, including protease inhibitors, NNRTIs, and INSTIs, which we commonly refer to as anchor drugs. In 1996, we began treating patients with combination therapy, or HART, involving drugs from different drug classes in order to improve HIV clinical care outcomes and primarily mortality. A decade later, in 2006, the first single tablet regimen was approved in the form of Atripla, a co-formulated pill with 3 drugs from different classes. And then in 2012, a pharmacologic option for pre-exposure prophylaxis came onto the map in the form of Truvada. All of this paved the way for the groundbreaking news in 2021 that long-acting injectable ART was approved for HIV treatment in January 2021 and prevention in December 2021. Beginning first with treatment. Over time, increasingly effective, tolerable, and simplified oral ART has developed, advancing from treating patients with multiple pills multiple times per day to treating with 1 pill daily, again, typically involving the co-formulation of 3 drugs. At the end of 2021, there were over 30 oral ART options that are FDA approved for use in the treatment of HIV infection. Most persons with HIV today are treated with 3 total drugs comprising 2 NRTIs and an anchor drug, and ideally this is in 1 daily pill. In January 2021, 2 injections administered monthly and now potentially bi-monthly in the form of Cabenuva was approved for use for HIV maintenance treatment. This novel co-packaged product comprises 2 drugs, including cabotegravir, an INSTI, and rilpivirine, an NNRTI. And the administration schema is as shown here. It begins with an oral lead-in, comprising 2 pills daily for 30 days to assess tolerability of both agents. And this is followed by the injectable phase, including a loading and maintenance, and then followed by maintenance dosing of 2 intramuscular intragluteal injections given monthly or bi-monthly. It's important to note that the clinical trials leading to the approval of Cabenuva required patients to have several months of virologic suppression prior to beginning Cabenuva. 2 phase 3 randomized open label clinical trials have now shown that LAI Cabenuva is not only efficacious, but safe and preferred over oral ART, as shown here by the 96-week data from FLAIR, which enrolled ART-naive patients, clearly demonstrating that Cabenuva, shown in green, compared with standard oral ART in purple, met the non-inferiority margin. Further, patient satisfaction for LAI Cabenuva was extraordinarily high, despite 88% of patients reporting injection site reactions, and similar results were observed in ATLAS, which enrolled ART-experienced patients, as well as ATLAS 2M, standing for 2 months or bi-monthly, which led to the approval of Cabenuva for bi-monthly use in the very recent past, as of about 2 weeks ago. Per FDA label, LAI Cabenuva is indicated as a complete HIV-1 treatment regimen as a replacement for current ART in those who are virologically suppressed on a stable regimen with no history of treatment failure, no known or suspected resistance to either CAB or rilpivirine, and no hypersensitivity to either agent. Additional contraindications include active hepatitis B, not otherwise treated, pregnancy, and drug-drug interactions. In considering use of LAI Cabenuva for HIV treatment, it's important that we strongly consider which patients may be interested, which meet eligibility criteria, and which may stand to benefit the most. And as you may imagine, these domains may not be overlapping. We should evaluate whether real-world interest and willingness to switch among persons with HIV balances clinical trial enthusiasm. And in terms of considering who may stand to benefit the most, we must consider those who have pill aversion, intolerance, or fatigue, suffer from malabsorption, or special consideration to populations with historically lower rates of viral suppression, including persons who are unstably housed and therefore don't have a safe place to store medications, in addition to transactional sex workers, persons suffering from stigma, or comorbid mental and psychosocial issues. I'm sure it's apparent that the current label use may not match those persons with HIV with the greatest needs. Shifting gears to the prevention landscape and expanding our toolkit from the early days of HIV prevention with non-pharmacologic measures, followed by the addition of Truvada and Descovy, approved in 2012 or 2019 as tenofovir-based PrEP, which is important to note that both of these single pill daily options, each comprising 2 drugs, reduce the risk of getting HIV from sex by 99% when taken as prescribed, and I'll emphasize as prescribed. Now, in December 2021, we have approved a bi-monthly injection comprising 1 drug, which is long-acting cabotegravir, which was approved for use in late last year after 2 RCTs were stopped early due to efficacy. Shown here are the results from HPTN 083, which enrolled cisgender men and transgender women who have sex with men in the Americas and Asia and South Africa, which clearly showed superiority of LAI CAB compared with standard of care being Truvada. And similar results were observed in terms of superiority among cisgender women who were enrolled in HPTN 04 in sub-Saharan Africa. This led to the approval for use in at-risk adults and adolescents greater than or equal to 35 kilos for PrEP to reduce the risk of sexually acquired HIV, with the oral lead-in being optional in this instance. Important clinical considerations for use of LAI CAB for prevention, namely in the participants in whom HIV infection was diagnosed after exposure to drug, INSTI resistance was detected and delays in detection of HIV infection occurred. There is a boxed warning to not use drug unless negative HIV test is confirmed prior to each use. It's also important to note that performance of HIV tests differs among those who acquire infection on ART versus those not on ART, meaning retrospective analysis of the trial data showed lagged antibody antigen positivity compared with viral load or RNA testing, and this was exacerbated among those who were on LAI CAB compared with Truvada. I want to highlight an important clinical resource put forth by the CDC, which is a warm line for PrEP-related diagnostic dilemma questions and concerns. In our final moments, I will briefly share firsthand observations from implementing LAI ART at the Grady IDP or Ponce de Leon Clinic using LAI ART for HIV treatment in a pilot program. To oversimplify implementation, I've categorized into 3 domains. First, building an administration infrastructure. Second, considering the patient. And third, accessing the drug. In terms of the infrastructure, medication cold chain supply and storage are required, in addition to the need to train personnel for IM and specifically intragluteal administration, which would ideally occur in a private space, and dedicating staff to intensive patient tracking and monitoring for tolerability, adherence, and virologic suppression. In terms of considering the patient, I believe that LAI ART has the potential to make a great impact for many types of patients in many ways. And in terms of accessing the drug, this has been the most complicated piece. There are different processes for obtaining the oral lead-in versus the injectable phase of drug, and coverage can either be via medical or pharmacy benefits, which differs by payer source and may not always be transparent. And unfortunately, inequitably, drug is not yet on formulary for all payer sources. So across the spectrum of implementation, themes have emerged, including the need for a multidisciplinary team comprising clinicians, pharmacy, nursing, additional support staff with medication access coordination and patient navigators to not only support and sustain, but also to scale up LAI ART in the real world. The second being one of equity. At each phase of implementation, we have had the opportunity to reflect and think critically about how we can best pursue equity and rolling out LAI ART as to not widen existing healthcare disparities in HIV medicine. So with that, I will conclude by sharing that realizing the full potential of LAI ART means being able to offer this treatment equitably. We can begin with including or understudied populations in clinical trials, namely pregnant women, those breastfeeding, youth, in addition to persons with HIV who may have suboptimal ART or clinic adherence and may actually even be viremic. And this is being currently investigated by ACTG protocol by the name of Latitude. We also must think creatively and evaluate strategies in order to improve medication adherence, including the possibility of truncating or eliminating the oral lead-in and pursuing direct to inject. Thinking about administration more broadly and outside of the brick and mortar clinic, using community hubs or mobile health units, and even exploring options down the road for home administration by training self or partner. All of this could be supported by adherence clubs in the community. And we must absolutely dedicate resources to scaling up LAI ART implementation in resource-limited settings, considering supply chain issues involving the need for refrigeration, needles, viral load, and resistance testing. And finally, continue to develop and assess novel agents as well as delivery systems for HIV treatment and prevention. We need to act now to capitalize on this unique opportunity of LAI ART to improve care delivery and outcomes for all persons with HIV and those at risk. With that, I would like to give special thanks to Drs. Armstrong, Colasanti, and Kelly for their expertise and support in preparing this talk, as well as their steadfast advocacy for our patients. And I'd also like to acknowledge our patients who are willingly switching to LAI ART and sharing their experience with us. And I look forward to any questions during the Q&A, as well as additional discussion. Thank you.
Thanks so much, Lauren. Jess, do you want to launch your slides? That's it's such an exciting moment in HIV care to think about giving an injectable therapy every other month and being able to control folks' virus. So perfect. That looks fantastic, Jess.
Okay.
Dr. Howard Anderson, you have the time.
Can you hear me? It looks like my Zoom is trying to crash.
You sound great. No, you don't. You're intermittent.
Okay.
Let's give it a try. Do you want me to flip to Dr. Workowski first?
I can try again. I don't know. It just crashed. Can you see it now?
Yes.
Okay. So thank you all for having me here. I'm going to talk about guideline updates for Clostridioides or C. diff management. So in the interest of time, I'm going to skip the usual background slides on C. difficile. I'm sure this audience is aware of the prevalence of C. diff and really the devastating impact the disease can have on our patients. This talk is really going to talk about the new updated clinical guidelines that were published in June of 2021. They were endorsed by the Infectious Disease Society of America, as well as the Society for Healthcare Epidemiology of America. And these are focused guidelines to provide an update from the last guidelines that were published in 2017. And so there are just 3 recommendations that focus primarily on fidaxomicin, as well as bezlotuximab. I'm going to focus today on the infectious disease guidelines, but I wanted to point out that there are guidelines also by the American College of Gastroenterology that were recently updated around this same time, and I'll try to highlight any major differences between the two. So to set the stage, we have an example case here of a 70-year-old female with high blood pressure and non-insulin dependent diabetes. About 3 weeks ago, she was given a course of antibiotics for a UTI. And she's now coming in of 3 days of abdominal pain, cramping, watery diarrhea, some fevers. She's never had anything like this before. There's a mild elevation in her white blood cell count, as well as an AKI. And this case is not meant to be a mystery. She tests positive for C. diff on our toxin and PCR tests. And this brings us to our first clinical question of what is the recommendation for treating this patient with her initial episode of a C. difficile infection. So that's exactly what the guidelines address in their first recommendation. And they say that for patients with an initial episode of C. diff infection, that they suggest using fidaxomicin rather than a standard course of oral vancomycin. This was a change from the 2017 guidelines where they recommended either vancomycin or fidaxomicin. And that was, at that point, a change from recommending it over metronidazole for non-severe disease. What was the rationale for this recommendation? You may be wondering what fidaxomicin is. It's an oral antibiotic. It was approved by the FDA in 2011 to treat C. difficile. It's usually given as a regimen twice a day for 10 days. Similar to oral vancomycin, it has minimal systemic absorption, and it's considered to be very narrow spectrum, so it doesn't treat any other disease, and it's thought to cause less disruption of the normal gut microbiome than some of our other therapeutics. So the guideline panel actually looked to see if there were any new trials since the last guidelines were published in 2017 comparing oral vancomycin to fidaxomicin. And they found 2 RCTs here, which I've displayed below. Geary et al. Actually compared sort of a unique regimen of fidaxomicin they called an extended pulse, which they gave fidaxomicin 200 BID for 5 days and then did every other day out to day 25. And they compared that to standard 10-day dose of vancomycin. They looked at sustained clinical cure at 30 days, so essentially meaning no recurrence in C. diff by 30 days. And they found that those that had received fidaxomicin had a higher chance of having a sustained clinical cure with an odds ratio of 1.6. The second study was also an RCT comparing sort of the standard regimen of fidaxomicin and vancomycin. Their primary outcome was actually global clinical cure, which they did not see a difference in. But one of their secondary outcomes, they looked at recurrence rate primarily at 30 days. And they did see that those that received fidaxomicin had less risk of recurrence. So then the panel combined these 2 new trials with 2 older non-inferiority studies that were included in the original 2017 guidelines. And they did a pooled analysis and found that fidaxomicin was associated with sustained clinical response at 4 weeks with a risk ratio of about 1.2 and a number needed to treat of about 10 patients. They did not, however, find any difference in the initial cure rate of C. diff, so right at the end of therapy, or difference in adverse events or all-cause mortality at 4 to 12 weeks. The panel emphasized that this recommendation prioritizes reducing the risk of recurrent C. diff, as that's been associated with a significant negative impact on quality of life in patients. They posit that fidaxomicin might be more palatable to patients as it's a BID regimen as opposed to vancomycin, which is usually 4 times a day. And while fidaxomicin may be more expensive at the individual level, there's been some cost effectiveness analyses that have shown that at a system level or for the population, it may be cost effective because of the decrease in C. diff recurrence and associated hospitalization costs. So there are, of course, implementation concerns, which the guidelines address and state that vancomycin remains an acceptable alternative. This is largely based around cost. If you go to GoodRx and plug in fidaxomicin, you'll see that without insurance, a standard 10-day course of fidaxomicin costs over $4,000. And even with insurance, it is still expensive and hard to get this drug. So there was a study that came out in October of last year, just looking at patients on Medicare Advantage plans or specific Part D formulary plans. And they found that fidaxomicin was on formulary most of the time in 84% of these plans, but it was really not very accessible. And in 97% of the cases, it was in tier 5 or the most expensive kind of category of copay. So our patient actually gets treatment with fidaxomicin, but unfortunately 3 months later, she calls again with recurrent diarrhea, abdominal pain, and she's diagnosed with recurrent C. diff infection. So this leads to the second recommendation from the guideline paper, in which the panel recommended that in patients with recurrent C. difficile infections, that they suggested the use of fidaxomicin as either standard or extended pulse regimens, rather than a standard course of vancomycin. This was again a change from 2017, where either a tapered or pulsed regimen of vancomycin or a 10-day course of fidaxomicin was recommended without any preference there for the first recurrence of C. diff. So what was the rationale for this change in the recommendation? Well, they again looked to see if there are any new RCTs since 2017. There was just one that they focused on, the Geary paper, which I already mentioned, which was an RCT comparing fidaxomicin as an extended long pulsed regimen to our standard 10-day course of vancomycin. In their pooled analysis here, they only looked at the subgroup of patients that had at least one recurrence. And so this dropped the sample size from over 1,600 patients to just over 250 patients. They did again find that fidaxomicin was associated with a sustained clinical response at 4 weeks, but there was no difference at actually response at 90 days, initial cure, adverse events, or mortality. Some other caveats for this recommendation, as I mentioned, it's a relatively small sample size in the pooled analysis, and it was all done based on subgroup analyses. So the panel concluded that this was a low certainty of evidence. All of the RCTs compared fidaxomicin to a standard course of vancomycin and not a tapered regimen, which usually involves slowly decreasing the dose of vancomycin over multiple weeks, which is often what is done for recurrent C. diff. There are, of course, implementation and cost concerns, as I already mentioned. And because of all this, the panel stated that vancomycin in a tapered or pulsed regimen is an acceptable alternative for the first recurrence of C. difficile infection. They also comment that for patients with multiple recurrences of C. diff, we really don't know what to do. And there's not a lot of data on how vancomycin in a tapered approach versus vancomycin followed by rifaximin versus a fecal microbiota transplant compares to fidaxomicin. Moving along to the last recommendation, this is also for patients with recurrent C. difficile infection and primarily focuses on patients that have a recurrent C. diff infection in the last 6 months. the panel suggested using bezlotuximab as a co-intervention along with standard of care antibiotics, so primarily oral vancomycin or fidaxomicin, rather than just standard of care antibiotics alone. This was an update from 2017 where there was really no guidance given on bezlotuximab at all at that point. Bezlotuximab is a monoclonal antibody against the C. difficile toxin B. It was approved by the FDA in October 2016 for the prevention of recurrent C. diff in high-risk adults. It's given as a one-time infusion, usually over 60 minutes. And there are no absolute contraindications to using bezlotuximab, but in a post-hoc analysis done by FDA, they found that patients with a history of CHF had an increased risk of having severe CHF exacerbations. And so that did lead to an FDA warning about the use of bezlotuximab in patients with CHF. The rationale for this recommendation largely comes from this New England Journal of Medicine RCT that was done in 2017, looking at over 2,600 patients. They compared bezlotuximab versus placebo in addition to standard of care antibiotics. But this study really took place between 2012 and 2015 or so. And so at that time, the standard of care antibiotics included vancomycin, primarily in metronidazole. So you can see they're about equally split here in the patient population. And very, very few patients received fidaxomicin at that point. Their primary endpoint was recurrent C. diff at 12 weeks. And they did find that bezlotuximab reduced C. difficile recurrence, 17% versus 26% in the placebo group, with a relative risk of 0.62. Then the panel, though, really wanted to, for the guidelines, look at which patient population may benefit the most from receiving bezlotuximab as an adjunctive therapy. And so they did a post hoc analysis where they actually got additional data from the sponsor based on that original trial. And they looked at their outcome of recurrent C. diff at 12 weeks, but they divided it into patients that had at least one episode of C. diff in the past 6 months. And they found that for that group, the absolute risk difference here was 17% in the patients that received bezlotuximab, versus just an absolute risk difference of 9% in patients that had an initial episode that it was their first episode of C. difficile that received bezlotuximab. And this data is actually really where the guideline took their recommendation from in terms of recommending bezlotuximab as adjunctive therapy for patients with a prior history of C. diff infection in the last 6 months. There are remaining questions here, specifically centered around, are there any high-risk individuals who should receive bezlotuximab for their first episode of C. diff infection? And another post-hoc analysis actually looked specifically at this, and they found that for patients that had some of these risk factors, including age greater than 65, being immunocompromised, or having severe C. diff on presentation, then bezlotuximab, which you see in red here, really did seem to reduce the risk of C. diff recurrence compared to placebo in gray. But for the patient population that had none of those above risk factors, there really wasn't much of a difference at all between getting bezlotuximab versus getting placebo. And this may be why the American College of Gastroenterology has really focused their recommendation about bezlotuximab based on risk factors and not necessarily just a recurrence in 6 months. And then lastly here, I'll just point out that the major gap and caveat for this recommendation is that there's really little data for how bezlotuximab may reduce the risk of C. diff when it's used in combination with fidaxomicin. And so as I pointed out, that wasn't really studied at all in the primary study. And now that fidaxomicin is being recommended more as first line, we don't know how bezlotuximab would help that group. There are, of course, implementation concerns as well, driven by cost primarily, and the guideline panel points out that many patients have difficulty receiving bezlotuximab even after referral, most commonly due to insurance denials. For Emory Healthcare in particular, use of bezlotuximab in our guidelines was recently reviewed in October of last year by our Committee on Antimicrobial Stewardship. It's actually been on formulary for the transplant outpatient infusion center since June of 2017. And we're now working on a process to roll it out for more of the outpatient clinics and infusion centers based on patients. It's going to be specifically recommended for patients with recurrent C. diff in the last 6 months, and in general who have risk factors. Again, as I already mentioned, for recurrent C. diff. Does cost almost $4,000 a dose. And on the inpatient side of things, it is now being recommended to be made formulary, though restricted to infectious disease, and will generally be reserved for high-risk population with an anticipated prolonged hospital stay who can't get it as an outpatient, because really there isn't any benefit in the acute disease presentation, and it's sort of operationally easier to give in the outpatient infusion centers. So in conclusion, I've discussed that the new guidelines have shown that fidaxomicin is now preferred over vancomycin for the treatment of initial and recurrent episodes of non-fulminant C. difficile infection. Bezlotuximab is suggested as an addition to fidaxomicin or vancomycin for patients with recurrent C. difficile infection in the last 6 months. And these new recommendations really prioritize efficacy, especially minimizing risk for recurrence, but they can be challenging to implement equitably. And more research is needed directly comparing fidaxomicin versus fecal microbiota transplant versus bezlotuximab alone. If you forget everything I said, you can refer to the guidelines, which really have a nice table laying out all the different treatment options. I want to thank the Emory Healthcare Antibiotic Stewardship team, as well as all the people on this slide here, and I look forward to taking questions.
Thank you so much. That's really a change in the way that we've approached C. diff, I think, for a while. Dr. Workowski, are you ready to share some slides?
Yes, I am. If you're ready to see some pictures.
We always count on you for pictures. You're in presenter mode, though.
Yes, so thank you for the opportunity, and thank you, Lauren and Jess.
Kim, you're in the like double view mode.
Oh, okay. Let me get rid of this one.
I think if you go to the display settings.
Let me get out of this. Okay, how's that?
Now hit the slideshow.
There we go.
No, go up to display settings at the top.
Okay, how's this?
You're still on the presenter with the two. There. Perfect.
Okay, there we go.
Fantastic.
Sorry, guys. Okay, so I'm going to take you on a quick tour through what's new in STDs. And we'll first start by showing the stark reality, which is for the 6th year in a row, we've had record increases in sexually transmitted infections. And these are the most recent data from the CDC from their yearly surveillance report. What I list on the right-hand side of this, the screen is something you may not have seen, but it was a report that came out from the National Institutes of Health on the National Strategic Plan for STDs. And just as we have a strategic plan for HIV and viral hepatitis, we now have one for STIs. So what are our prevention challenges? I showed you these incredible numbers, and these are the challenges we currently have. There's an ongoing syndemic of HIV, STIs, viral hepatitis, and substance use disorder. Intermixed within that are the health disparity and stigma associated with STIs. Most of our STIs have atypical presentations or they're asymptomatic. We as clinicians at the point of care have very limited point of care diagnostics. We don't have anything except for a simple gram stain. We don't have a point of care test for patients that present with genital ulcer disease. I'll also show you the problems we're having with antimicrobial resistance, both in Neisseria gonorrhea and Mycoplasma genitalium. And then COVID has disrupted a lot of things. One of the things it did was close STD clinics. There were also problems with antimicrobial shortages when azithromycin was the rage a couple of years ago. And we have had continued problems with our supply chain and diagnostic molecular test kit shortages. So to think why these are relevant. And Lauren gave a wonderful talk on HIV. I just wanted to remind us both on primary syphilis and rectal STIs that increase the risk of HIV acquisition. And these were several elegant studies that were done several years ago in New York, but really important thinking about if a man who has sex with men obtains rectal gonorrhea or chlamydia or primary secondary syphilis, 1 in 15 or 1 in 18 were diagnosed with HIV within a year, compared to those that had no rectal STIs or syphilis infection. So very stark. Also on looking in women, vaginal dysbiosis or bacterial vaginosis increases the risk of several STIs. So again, both in men and women, these are very important for the risk of HIV acquisition as well as reproductive tract mortality and morbidity, more in women than in men. So what can we do as clinicians? We have some prevention tools, both a behavioral risk assessment that you should think about incorporating into patients that present into your care. Just as you talk about alcohol, tobacco, depression, we should talk about sexual risk factors, including number of partners, practices, are you using protection, what are your pregnancy preferences? And then think about what we can do biologically to screen for STIs. And what I list for you on the right is the recommendations both from the STI treatment guidelines as well as US Public Service Task Force on what you should be screening for in women, men who have sex with men, and men who have sex with women. And what's different here is there is now a recommendation for permissive rectal swabs for women to look for chlamydia and gonorrhea. And I'll talk to you about why that's important when we get to that particular section. Also, the importance of vaccinating for human papillomavirus and hepatitis A and B, which are sexually transmissible. And there is a large section in the treatment guidelines on all the various prevention methods, including condoms, PrEP and PEP, both for HIV and STI prevention. So we'll start with syphilis. And on the left-hand side of your screen, you'll see some of the figures from the surveillance report from CDC showing over time the continued increase in syphilis rates. What I want to really highlight, though, is the decrease in the male to female ratio and the dramatic increase in female syphilis, which has led to an increase in congenital syphilis. What you see on the right-hand side of your slide is a really nice figure trying to explain the intricacies of syphilis. And one of the things that I think is hard for people to understand or remember is that it is not a simple progression from primary, secondary to latent. You can go from secondary to latent and then back to secondary. And the presentation is extremely varied. We're seeing an increasing presentation of cardiovascular syphilis, increasing of CNS syphilis, ocular syphilis, and otic syphilis. So again, if you know syphilis, you know medicine, and it's very challenging to diagnose. On this next page, this will wake you up a bit. This is some dramatic presentations of patients that I have seen with dramatic presentations that are syphilis. And looking at this, you may think some of these look similar and to what you've read about or seen, but I point to a couple. And this is a patient here with secondary syphilis only manifested in the throat with some mucus patches and an exudative pharyngitis. The rashes are all different. So any potential rash can be syphilis. This patient here was a patient with advanced HIV that was not able to develop an immune response to syphilis and had completely negative serologic testing. So this syphilis continues to baffle us all. And the other problem with diagnosing syphilis is our tests are decades old. They're not perfect. And they're very challenging. It's a use of a traditional algorithm would include a non-treponemal test followed by a treponemal test. But again, the importance is here in red, patients presenting with primary syphilis, almost 30 to 40% of them will have a false negative RPR. However, the treponemal test should be positive in those instances. So in particular, if you're concerned with somebody that presents with a primary lesion that you're concerned about syphilis, make sure you have both the RPR and the treponemal test. Using the traditional versus the reverse sequence algorithm, where you would start with a treponemal test followed by an RPR. The problem with this kind of algorithm is that you can have a false positive test, and it does require RPR confirmation. One of the key tenets of syphilis diagnostics, however, is down here below. Never interpret a serology in the absence of a clinical history or previous RPRs, because it's very important to link that test with where the patient is, what you see, and what they've had in the past. In terms of syphilis treatment, important tenets on this slide. The traditional treatment for early syphilis, primary, secondary, or early latent, is a single shot of benzathine, regardless of whether you have concomitant HIV infection. There's been a number of studies in the past that have looked at whether enhanced therapy makes a difference. There's no data that it does. To answer that question, we are currently conducting an RCT of 1 shot of benzathine versus 3 for early syphilis to definitively answer the question. The NCT number is here. If you have any patients would be interested in enrolling them. What are the alternatives to penicillin in somebody that's truly allergic? We do have some data, although not the best, on doxycycline, more limited data on ceftriaxone. And people tried to be creative during the pandemic when they couldn't get benzathine. And so they were putting amoxicillin with probenecid. There's no good data. There is some pilot data on looking at sulfixene, but again, I would not advocate its use. It is just pilot data at this point. What you see in the top right is a graph from a paper that we just recently published on a trial, that the ongoing trial of the RCT on benzathine, using benzathine 1 versus 3. And this really points out something very important, which is that patients at presentation with syphilis, over 50% in our 9-site study had a concomitant STI. So remember to look for other STIs. The other thing that's important here is the serologic response after you treat somebody with syphilis has changed. Primary, secondary, and early latent, we're now looking for that 4-fold titer drop to be 12 months instead of 6 months. And in HIV patients with HIV infection with primary, secondary, early latent, it may take 24 months for them to drop their titer. Moving from syphilis to patients that present with urethritis or cervicitis, I list for here the most common organisms associated with urethritis or cervicitis: chlamydia, gonorrhea, and mycoplasma genitalium. Those are the 3 I'm really going to concentrate on in the next couple of slides, but there's a number of other organisms that can cause this. Ureaplasma is not a cause in the literature of consistent urethritis or cervicitis and should not be tested for. What you should do if somebody presents with urethritis or cervicitis is get a nucleic acid application test for gonorrhea or chlamydia. The preferred specimen in a woman is a self-collected vaginal swab or first cut urine in a man. You can't do antimicrobial resistance testing, and because of the high rate of recurrent infections, you need to retest in 3 months. If somebody comes back in and has persistent urethritis, that's when you test for Mycoplasma genitalium and trichomonas in a men who has sex with women, not an MSM, because there's not an increased risk of trichomonas. In a woman with persistent cervicitis, you can find other reasons, including dysbiosis, douching, or dysplasia to cause that cervicitis. So the big news in chlamydia is really the difference in treatment. And we first started noticing this a couple of decades ago in a number of RCTs that were done for non-gonococcal urethritis. And as you see here, what we noticed over the last couple of decades is that azithromycin effectiveness was decreasing. And then we started having some observational studies showing this frank difference in effectiveness when looked at rectal chlamydial infections. And most of these infections in these studies were asymptomatic. We really didn't have RCT data until recently. These two trials, both in the New England Journal and in Clinical Infectious Disease, both demonstrated a stark difference in treatment efficacy for chlamydia. These two studies were done with asymptomatic infection, chlamydial infection in men who have sex with men, showing a dramatic difference, as you can see here, 100% cure rate with doxycycline, 74% cure rate in azithromycin, depending on whatever way you wanted to cut the data. Same data, same kind of study that was done, looking again at stark differences. So the recommendation for chlamydia is really changed to doxycycline now, and azithromycin should not be used as primary therapy because of this dramatic decrease efficacy of azithromycin for chlamydial infection. Also wanted to mention that chlamydia, some strains can cause atypical presentations. And proctocolitis, this is the typical lymphadenopathy you might see. This is a patient I recently saw that presented with a perirectal papule. And that's sometimes how chlamydia LGB can present. This was a pseudotumor in a rectum that people thought was a malignancy. And this is an oral ulcer here due to LGB. So STDs continue to have very different presentations. If you're concerned about LGB, you would use doxycycline for 21 days instead of 7, and you would have to get a genotype to confirm. If you're concerned about it, you treat for 21 days and wait for that genotype to come back. For gonorrhea, gonorrhea can cause a number of different syndromes in men and women. But what I really want to concentrate on is what's new in disseminated gonorrhea. This is, you may have remembered back years ago that the traditional teaching, gonorrhea disseminated very infrequently, and mostly it was seen in women around the time of menses or pregnancy. And it presented as either a monoticular arthritis or skin lesions and tenosynovitis dermatitis syndrome. What we've seen is 2 big articles now. One you see in an MMWR that was published a couple of years ago, and a paper that we just published in Clinical Infectious Disease that's showed a dramatic shift in the epidemiology. And that's a change from women to men, increase in the reported drug use, mostly associated with meth and opiates, and an increase in age. In the study that was just done showed 40% of the patients were over 45 years. So again, dramatic shift. What's changed with gonorrhea has been the treatment recommendations, and that is really based on CDC data that has a ongoing surveillance system that we can monitor for antimicrobial resistance. And this is one of the factors that is used to determine which antibiotic or combination of antibiotics we should use for treatment for gonorrhea. We can take this data and then become more granular and look at the MICs, track them per year, track them by sex of sex partners, and give you recommendations for treatment. And basically using this information, both on the surveillance, thinking about antimicrobial stewardship, thinking about PK/PD, and the superior efficacy of the doxycycline I just showed you, the recommendations have changed to include ceftriaxone as monotherapy for the treatment of gonorrhea, or if chlamydia has not been ruled out, you're going to also treat with doxycycline for chlamydia. I'm just going to skip this in the interest of time. I will just end with Mycoplasma genitalium, which causes about a quarter of urethritis. We don't know much about its natural history. We're still learning about this organism. We do have an assay available for it. Where I would like you to consider using it is in men that have persistent NGU, women that have persistent cervicitis, and we may consider in PID. The problem really is, again, antimicrobial resistance. And you can see from these 3 trials that were done about the decrease in azithromycin effectiveness. Doxycycline is only about 30% effective, and it's decreased over time. The only quinolone that works in the United States is moxifloxacin. All other quinolones here are ineffective. This just shows you current data, which shows that the prevalence in men presenting to 6 STD clinics with urethritis, 28% of them had M. genitalium, and most of them had drug-resistant M. genitalium, mostly from what's in here in the blue is macrolide resistance. And so basically what we're left with is we have a test to detect Mycoplasma genitalium, but we don't have resistance tests available. And a country that does have a resistance test available, I wish we had that here. With the use of a resistance test, you can actually determine whether or not to use a quinolone or to use a macrolide, and it does work. We don't have that available here in the US yet. So what we have is the recommendations. If you diagnose M. genitalium, you're going to start with doxy. Even though I told you it's only 30% effective, it will decrease it will decrease the load, and then you follow that with moxie. And so these are the recommendations. We hope to have resistance testing here in the US, hopefully in the next year or 2. So I will just end with all questions regarding STIs are in the STI treatment guidelines. There's also recommendations for screening. You can download an app. And I want to thank the multitude of people that helped me in terms of developing these. So thank you so much for your attention.
Thank you so much, Dr. Workowski. We are actually after the hour. So I don't think we have time for questions. Dr. Workowski, if you could maybe put a response to Dr. Higgins's question about trick in women in the chat, that would be awesome. Or actually say, if you can answer quickly, updated treatment guidelines for trick in women.
Yes, trick in women, 500 milligrams twice a day for a week. No longer single dose therapy, based on a trial that was done a couple of years ago.
Perfect. Thank you, 3. This was fantastic. I really enjoyed it. And thanks to the audience. We'll see you next week.